you have a lot of clinical prediction models already out there. Most of these are predicting a single health outcome. So, for example, there's one called Q-Risk, which is very popular in the UK, and it predicts the risk of having a heart attack in the next 10 years. And that's an example of what you call a time to event outcome in a clinical prediction model. So it's an outcome that happens once. Our model's a little bit different because it's epilepsy. So your outcome that you're interested in is a seizure, and that's something that can obviously happen lots of times. So that's what we would call a recurrent event prediction model. And there's not as much methodology out there in statistics for a model like this. So we've had to kind of slightly optimize some of it ourselves, actually, in certain places, not in the predicting part, but then later on in the validation process, which I'll talk about as well. So we've used, when we've created this model, we've used what's called a Cox proportional hazards model. It's a very popular time to event model, but we're using extensions of that. So there are two extensions of that which we've looked at. One of them is called Andersen-Gill. The other one is called Prentice-Williams-Peterson. And the difference between the two essentially is that Prentice-Williams-Peterson would give you a slightly more accurate prediction in theory, because it's much more interested in the timings between the events that it's predicting, in this case seizures. But then we look at both because there's a risk of what's called overfitting data. So PWP or Prentice-Williams-Peterson, it might predict the results much more accurately with our data set, which we've built our model with, but then it might not actually predict more accurately a realistic population, because it's fitting that model that we have, that data set that we have to sort of specifically, I suppose. But we've done our tests. With both approaches, and we've externally validated as well. So we built our models using SANAD, which is one of the great epilepsy trials, we'd like to think, which was conducted here in Liverpool. And it tested it was looking at some fairly novel drugs and comparing with the sort of the standard anti-seizure medication, which I think is still being used now. It was conducted over 20 years ago, but it's a very, very high quality data set, excellent balance between all of the kind of different characteristics that are measured. So things like sex, age, but then more clinical ones as well, like EEG results, CT scan results, that sort of thing. And then as well, what we've done is we've validated this externally. So in other words, we've ran this model and seen how well it can predict people with much more up-to-date data. And the data set we've used for that is SANAD-2, which was a follow-up clinical trial to SANAD, which was conducted only a few years ago. So by externally validating with this much newer data set, we have a great idea of how representative the population is that we're predicting in our models, meaning that we can quite confidently say that we would be able to predict results for people today, rather than just the people that we use, whose data we used in the trials before. I'd also just like to thank Laura Bonnet, who's the principal investigator for this project. This project is all by her design. And I'm also working very closely with Alexandra Hunt, who's another medical statistician on this project. She's been doing a lot of the validation, and Beth Morris, who's been our qualitative researcher and is getting all the really useful feedback from the patients and clinicians alike. And then also as well, Tony Marston, who was kind of the brains behind the SANAD clinical trial, and he's been our top clinician that we've been lucky enough to consult at various stages of this project.